371 in medic 6. You're seeing a 74-year-old male, shortness of breath.
Sometimes it's called assault. Other times it's assault and battery, or just battery. Whatever term is used in your jurisdiction, it describes a violent event. Unfortunately, these violent events are all too common.
It's okay. Are you all right?
Assault occurs anywhere, in schools, workplaces, homes, or public areas such as bars, streets, and parks. The type of situation can range from a minor misunderstanding to gang violence, sexual assault, and even death. As always, scene safety will be your first priority.
The biggest challenge for EMS in assault cases is, number one, understanding the environment in which it occurred and whether there's any continued risk to the crew or to the victim. The second is our focus as an emergency medical crew has to be on the injuries or trauma associated with it. We have to do the life-saving things first. If the person has been beaten severely, we need to focus on their medical care, properly package the person, and make a good decision about the use of the trauma center. When it comes to then the third piece, if there is an assault, it will involve legal implications. That victim at some point will need to be talking to law enforcement, describing in detail what happened, getting information that would be necessary for prosecution of the person who assaulted them.
Your safety and the safety of your crew are paramount. These scenes are often dynamic, changing at a moment's notice. Never enter a scene unless it's secure. Confirm with dispatch if the scene is safe and if law enforcement is on scene or en route. Ask if the perpetrator is apprehended or at large and if any weapons were involved.
Sometimes domestic situations involve a lot of emotional tension and a lot of danger, and any provider who walks in first is at some risk that one of the members involved might strike out at them, might use a weapon. So the first thing that any EMS provider should look for in an assault case is the presence of law enforcement.
On arrival, assess the scene. Is the event still ongoing? Are additional resources needed? How many victims are there?
Hey, my name is Brandon. Can you tell me what happened?
Hold your neck. Don't move it, okay?
Okay.
What is your general impression? What additional equipment or resources will be needed? Also, survey your surroundings and identify an alternate means of egress.
Guys, do you know where you're at right now? Okay. Do you know around what time it is? Morning, evening, afternoon?
Based on your assessment, start formulating the plan. Who will perform patient care and who will monitor the scene? The situation should be continually monitored, and at no time should a provider be left alone. Being aware of your surroundings is a paramount concern.
Many jurisdictions, when it comes to assault calls or other violence calls, they have actually written rules for the EMS providers that they're not to approach the scene. They're to stage some distance away until law enforcement has cleared the scene and made sure that it's a safe environment. Some of those cases are relatively simple cases. There wasn't an assault involved. It was something different, and they can, of course, then be called in immediately.
Assault scenes are crime scenes until determined otherwise. You might find an assault victim at a location other than where the assault took place, but it is not your job to determine whether important evidence might be present. At a potential crime scene, don't touch or move anything unless it interferes with patient care. If you must move something, inform law enforcement and let them document the original location. Impact the scene as little as possible. If the patient can be moved to a more secure location without adversely affecting their condition, this may help preserve the scene.
There are some general guidelines. One is we attempt to leave anything that was there to begin with there, to help the police establish a story, to be able to collect the physical evidence that they need to. Blood stains, other bodily stains, tears in clothing, something that's ripped off the patient, whether it's hair or fingernails or other things that occasionally come off during assaults. If you leave all of that alone, we're better off. If you're going to have to take clothing off of the patient for some reason, we don't cut through bullet holes, we don't cut through the slash wounds from a knife. We leave that intact because that's important evidence for the crews.
Two types of injuries are common for victims of physical assault: penetrating trauma and blunt force trauma. Penetrating trauma can include gunshots, slashes, and stabbings, and can be dramatic in terms of their appearance and severity. But in many cases, the penetrating trauma is only the most visible of many injuries. Don't get caught up in treating the impressive injuries and missing subtle ones. A complete trauma assessment, keeping DCAP BTLS in the forefront of our minds, is vital.
How's that pain in your left side? It hurts? Do you have any pain in your left shoulder?
Blunt force trauma is almost always present in the assault victim. While usually less impressive than penetrating trauma, these injuries can be more severe. Blunt trauma is often a result of being struck or from direct pressure, such as being choked. Injuries can be difficult to detect in the field and even more difficult to treat.
We're going to get that collar and get you on the board, okay?
In the situation then involving assaults, then we do our specific trauma assessment with mechanism of injury, and then a set of vital signs, and finding all of the injuries, attempt to identify them, go through your set of ABCs in terms of life threats to the victim, begin to manage each of the ABCs that needs to be managed. And then look again, sometimes the victim has been so traumatized by what has happened to them that they disguise some underlying symptoms. In some cases, it's very hard to find their injuries because they may not know what happened to them, or they may not be able to appreciate it because of the emotional trauma that has gone along with it.
Unlike an accident, we might not know the mechanism of injury, and our patient might be unresponsive or so emotionally charged that they are not able to articulate what happened. These cases call for a complete trauma assessment focusing on the subtle. Your care and treatment begins, as always, with the ABCs and should include continually assessing for signs and symptoms of shock. Observe for increasing intracranial pressure, changes in skin color or condition, nausea, dilated pupils, and a rigid abdomen. Signs and symptoms of blunt force trauma include, but are certainly not limited to, unconsciousness, unresponsiveness, bruising, deformities, raccoon eyes, battle signs, and fluid emanating from the nose, mouth, and/or ears. Depending on the severity of injury, treatments may require immediate ALS interventions such as fluid resuscitation, pain management, cardiac monitoring, and advanced airway management. As always, follow your local protocols. After a thorough assessment and treating any life-threatening injuries, your next steps include preparing the patient for transport and determining which facility in your area is best equipped to care for the patient's immediate needs. Some hospitals have specially trained staff and rooms equipped to handle certain kinds of assault.
All emergency systems should have a setup and understand where the appropriate examinations are done across the wide range of potential ages of the victims. Contained within that are three pieces. One, what do we do with the traumatized patient, the badly injured patient, and how do we best deal with the injuries related to an assault that may be life-threatening for the victim? That then calls back into play the trauma protocols, the use of helicopters and other things in rural areas. Piece two is the general management of a patient who states they are assaulted in whatever fashion. Where do the law enforcement people best get their work done? How long are transport times? Some rural communities, the police would prefer to stay in town because they're the only law enforcement resource for the town, and they would prefer to complete an interview of an assault patient before the EMS crew removes them to a distant hospital. And so if there's non-life-threatening injuries, the EMS crew may be delayed at the scene for some time, allowing the law enforcement personnel to do their work. So in our very rural communities, that may be what has to happen. Again, don't compromise patient care. Make appropriate use of planning beforehand with law enforcement. Piece 3 is assaults of a sexual nature. Those may be female or male specific at different hospitals and in different regions. And there's also typically a breakout of pediatric versus adult or senior. And the EMS system should understand where all of those pieces will fit together and a plan for them.
As always, your thorough documentation of the incident and of the care you provide is critical. Not only is your documentation important for informing and directing the continuation of your patient's care, but it also may become critical evidence in any legal proceedings that stem from the event.
Extra to you that he might not have mentioned to me as far as who did this to him?
No, he told you that several people attacked him with a skateboard, and that's the only thing he told us.
Everything that we write in an assault case should be preceded by words like patient stated or bystanders stated, or that we were told by bystanders that, we were told by the victim that, so that we aren't judgmental in how we do any forms of our documentation in patient care. We have to be very specific in describing exactly what the patient says to us in certain circumstances. I don't want to overstate. Sometimes it's very obvious. You know, the person says, I was struck in the face once with a fist and I was not knocked unconscious, and that's fine. There are other circumstances where the victim may give us much more vivid details, and it really would help us if we would write down in quotation marks, specifically what the victim told us.
Your thorough documentation of the incident and of the care you provide is critical. It helps the emergency department staff provide the best support and continue additional treatment.
In talking with the emergency department, we should be as specific as possible about what happened and give a verbal report on that. Again, as far as safety is concerned, we should be clear to the emergency department whether there's an ongoing risk to the patient or not, whether the alleged perpetrator is in custody or not, and whether law enforcement is going to come into the emergency department to do some further work, or whether that has been completed at the scene. You're so worried about their injuries that you think they may die of them and never be able to talk to the sexual assault nursing staff, in which case you may document that. But otherwise, the description of a sexual assault is best left to the people that have very specific knowledge and understanding of the legal system. Let them do a complete interview. That's beyond the scope of practice of pre-hospital care providers in the emergency situation.
Sexual assault is another situation you may be called to treat. Typically, the victim of a sexual assault also suffers from additional physical injuries. In addition to your standard trauma assessments, sexual assault victims require special care and consideration. If the patient hasn't already, encourage her not to change her clothes. Clothing can contain evidence.
Does your clothes right there?
If any items have been removed, bag them and transport to the hospital.
Have you taken a shower since you got home?
Also, discourage your patient from any physical cleanup prior to an evaluation at the hospital. This includes cleaning superficial wounds or using the bathroom.
In some cases, the sexual assault is the primary problem, and sometimes it's a secondary. There's a variety of circumstances that can occur around that. We sometimes will know what we're involved in. You know, you can recognize that the victim has been severely injured and traumatized, and a sexual assault has occurred. And our focus again would be on the traumatic injuries. In other cases, the victim has received a sexual assault and nothing else has occurred in terms of injuries. In other cases that we have to deal with in the field and in the emergency department, the person believes that they were sexually assaulted, but were so under the influence of something either given to them or that they self-ingested that they really just don't remember.
Assault scenes are emotionally charged. The patient, bystanders, and even the perpetrator can be out of control emotionally. Also, drugs and alcohol can complicate the situation even more. Magnifying the emotional state of the victim makes treatment more difficult. Emotional responses you might expect include fear, anxiety, terror, grief, numbness, anger, resentment, hopelessness, despair, guilt, helplessness, and loss of control. You must be prepared to deal with these emotions. Providing emotional support or psychological first aid is a critical part of assault victim care. The patient's physical injuries might be minimal compared to the emotional trauma they are suffering. At its simplest, psychological first aid might be considered active listening. Not only should you listen with your ears, but your eyes as well. When a patient feels that you are actively listening, they feel your compassion and support. They may be more willing to talk about the event. This can help you identify any immediate treatment considerations. Some patients may not talk at all. Do not force them to communicate if they are unwilling.
It's all right, you're safe now, okay?
The EMS crews should be careful to only ask what is necessary for them to know in order to provide good emergency medical care, make a good decision about where to transport the patient to. If their injuries are bad enough from a trauma perspective, they'll need to go to a trauma center. In some communities, we have sexual assault specialty centers, and they would want to take the victim to the sexual assault center. And in other situations, a general hospital or general emergency department would be fine. In some cases, the victim would prefer to stay, complete their report with the police department, and then stay at home with their family members. That is a medical protocol issue, and if necessary, contact should be made with online medical direction.
It is an unfortunate fact of life that assaults take place. As an EMS provider, you must be aware of the assault victim's needs and provide for them accordingly. Also, watch for your inclination to want to fix everything and become over-involved. Keep your own emotions in check and concentrate on an appropriate provider-patient relationship.